Hi, everyone. Welcome. My name is Amber Gimmel, and I want to thank you all for joining today's member webinar. The title is Evaluating Genetic Diseases in Nephrology in Kidney Transplant Candidates and in Living Donors. Just a couple housekeeping items. We encourage questions to be asked throughout the presentation. As a courtesy to our presenter, all attendees have currently been muted. Please utilize the Zoom Q&A box for questions that you may have throughout the presentation. The chat function is also available for discussion throughout the talk. Questions will be read aloud during the last 10 minutes of the webinar. Today's learning objectives are as follows. First, recognize the importance of making a genetic diagnosis in nephrology. Understand that testing living kidney donors for genetic disease, if done responsibly, can inform risk of future ESRD and improve decision-making. And third, review case examples to illustrate the role and impact of genetic testing. I'm pleased to introduce our speaker today, Dr. Christie Thomas. Dr. Thomas received his MMBS or MD equivalent from Christian Medical College in Vellore, India. And after training in internal medicine and nephrology in Sunderland and Sheffield in the United Kingdom, and in nephrology and physiology in Cleveland, Ohio, he joined the faculty of the University of Iowa, Carver College of Medicine in 1992. He is currently a professor in the Department of Internal Medicine, Pediatrics, Obstetrics, and the medical director of the Kidney Transplant Program at Iowa. In addition to his work as a transplant nephrologist, he has a strong clinical interest in genetic kidney disease and established a renal genetics clinic, a first for this region. Working with the Iowa Institute of Human Genetics, he developed the first comprehensive renal genetic panel called KidneySeq, which uses targeted genomic enrichment and massively parallel sequencing to simultaneously evaluate nearly 400 genes involved in hereditary kidney disease. He is currently chairing two national committees, one for the American Society of Transplantation and the other for the American College of Medical Genetics, to develop practice resources and guidelines for the evaluation of genetic kidney disease in living donor to candidate. And with that, Dr. Thomas, I'll pass it over to you.
Thank you, Amber, and thank you, Amber and Jason and Maggie, for this invitation. Thank you, Amber, for the generous comments in your introduction. So the charge that I have today is to talk to you about all things genetic as it relates to nephrology. It is a rather broad topic, as you can see from the title, and I'm going to try and quickly cover some essential elements in general nephrology, in kidney transplantation, and in living kidney donors. I have no disclosures, and I think you've already heard of the objectives, so I'm not going to dwell on that. So let me start by introducing the idea of making a diagnosis. Genetic testing is one way to make a diagnosis, and it's obvious to you as genetic counselors why a diagnosis is necessary. It is obviously required to recognize the problem, to predict the course, prognosticate and determine management of any disease. And we make diagnoses using available tools. We do a clinical examination, we take a history, we identify a pattern of disease, we select diagnostic tests to help us narrow the differential diagnosis, and then hopefully we have a diagnostic test that establishes a definitive diagnosis. And genetic testing is sometimes a way to make a definitive diagnosis. Sometimes it's the only way to make a definitive diagnosis. So it is a tool to help us get to where we need to as we take care of patients with simple or complex diseases. In nephrology, we identify certain patterns of disease to help us approach the problem of diagnosis. And for those of you who might not be working currently in the nephrology space, the patterns of disease that we recognize as, if you will, distinct phenotypes are the cystic kidney diseases characterized by cysts in the kidneys, and the commonest type of cystic kidney disease is autosomal dominant polycystic kidney disease. It also happens to be the commonest cause of end-stage kidney disease from a genetic disease, and currently makes up about 8 to 10% of end-stage renal disease patients in the United States. The other phenotype is that of renal developmental defects, which are broadly called congenital anomalies of the kidney and urinary tract. And those are anything that looks developmentally abnormal. So renal hypoplasia, renal dysplasia, hypodysplasia, unilateral renal agenesis, unilateral or bilateral vesico-ureteric reflux, posterior urethral valves, they all come in under this broad category of CACUT, or renal developmental defects. Glomerular diseases are characterized by proteinuria, sometimes severe, with or without the presence of hematuria, which is usually under the microscope, sometimes with red cell casts. And those indicate that you have a glomerular disease process. And I've given you examples in all these cases of genetic diseases that can present with each of these phenotypes. So the commonest glomerular genetic disease would be Alport syndrome. And then we have Fabry disease and FSGS, which is a histological pattern of disease, which has sometimes a genetic cause. The fourth phenotype is a tubulointerstitial disease pattern where the patients have bland urine, minimal proteinuria, but don't have obvious developmental defects and don't have multiple renal cysts. And an example for that is autosomal dominant tubulointerstitial kidney disease. And finally, we have disorders of tubular transport, which does not present with a reduction in kidney function or with proteinuria or hematuria, but rather presents with distinct abnormalities in iron transports. It may present with hypokalemia or hyperkalemia, with metabolic acidosis, with phosphaturia, with kidney stones, with amino aciduria, and so on and so forth. And I've given you two examples of tubular transport disorders that you're probably familiar with: Gilman syndrome and Dent disease. So the tools we have to make a renal diagnosis, in addition to the history, the physical exam, and testing of kidney function, are imaging studies that give us a clue to CACUT or to cystic kidney diseases, kidney biopsy that can help sort out the causes of either tubulointerstitial or glomerular diseases, and then genetic testing. And genetic testing is not the only way we can make a genetic diagnosis, but all of these testing strategies allow us to localize the defect to a segment of the nephron. And again, for those of you who need a refresher, we have the renal cortex where the glomerulus is situated, and we also then have the proximal tubule, the Henle's loop, the collecting duct, and the Henle's loop is typically in the medulla of the kidney. For a disease like Gilman syndrome, it localizes to the distal convoluted tubule. A disease like Dent's disease localizes to the proximal tubule. We can make genetic diagnoses sometimes without resorting to genetic tests. And here is an example of what a urine with a patient with cystinuria might look like under the microscope. They have these classic pathognomonic hexagonal crystals of cysteine, only seen in the genetic disease cystinuria. And I've given you the commonest cause for cystinuria, which is a biallelic variant in the gene SLC3A1. Fabry disease, another genetic disease, that's an X-linked disease, and this is a kidney biopsy showing you these podocyte and endothelial cell inclusions that are characteristic of Fabry disease. Under an electron microscopy, you would see these lamellated inclusion bodies, which we call zebra bodies. This is a light microscopic image. You might pick up a genetic disease by MRI. And so this is an MRI of the abdomen showing you enlarged, distorted kidneys, completely or nearly completely replaced with cysts that are numerous and are of varying sizes. So that's a classic feature of polycystic kidney disease. And 95 to 99% of the time, this is due to one of two genes, PKD1 and PKD2, and this is an autosomal dominant disease. But sometimes the only way you can make a genetic diagnosis is by the traditional method of genetic testing, and that's a sequence chromatogram showing you a wild type sequence and a sequence in a person with Gordon syndrome showing you a heterozygous variant in the gene KLHL3 probably the commonest cause of Gordon syndrome, and KLHL3 causes autosomal dominant disease. So why make a genetic kidney disease? Well, a genetic diagnosis is a definitive diagnosis. Secondly, it may be more specific, cost-effective, and simpler. For a condition like FSGS, it's simply a biopsy diagnosis. It's descriptive with multiple etiologies, including some genetic causes. So a biopsy is not going to help you get to the bottom of the problem. When you have advanced chronic kidney disease or end-stage renal disease, a kidney biopsy at that point is very unhelpful because there is irreversible scarring without a distinctive original injury being evident. And for tubular transport disorders such as Gittleman's, there's no role for a kidney biopsy. A genetic diagnosis can also provide prognostic information on the expected outcome or progression. And here's an example of a Kaplan-Meier curve where you can actually separate people with polycystic kidney disease into one of three risk categories. On the y-axis is the probability of progressing to end-stage renal disease, and on the x-axis is time. So by age 60, most people with the red curve have got to end-stage renal disease, while those with the green curve, at age 80, there is still a significant number of patients who have not got to end-stage kidney disease. These curves are derived from a score called the PRO-PKD score, and what that tells us is that the median age of onset for loss of kidney function getting to ESRD is 50 years for the high-risk group and 80 or 70 plus years for the low-risk group. The PRO-PKD score includes 4 variables, including the nature of the genetic variant that's identified, with PKD1 truncating variants giving you a higher score compared to PKD1 non-truncating compared to PKD2. And it helps us predict the age of end-stage kidney disease for polycystic kidney disease patients. It can help predict the risk of post-transplant recurrence of disease, so atypical HUS, often due to a defect in an alternate pathway of complement, usually secondary to autosomal dominant variants in several genes. And if you found that atypical HUS is from complement factor H or complement factor I, it has a high rate of recurrence of disease without specific therapy. Another condition is primary hyperoxaluria, which is an autosomal recessive disorder where there is an enzymatic defect originating in the liver that prevents catabolism of oxalate that's produced. High levels of oxalate then destroy the kidney, and without treating it specifically, the disease will recur very quickly in the transplanted kidney. And then we have genetic FSGS. Many types of FSGS can recur in the transplanted kidney, but if you find that it is from a genetic cause, it has a very low rate of post-transplant recurrence. So continuing on to some more reasons to make a genetic diagnosis, it can offer therapeutic information. So eculizumab, a terminal complement blocker, is useful to treat atypical HUS and helps to prevent post-transplant recurrence. In addition to genetic FSGS not being prone to recurrence in the transplanted kidney, genetic forms of FSGS also tend to be resistant to steroids and immunosuppression, and therefore you can avoid the use of these toxic therapies in people that have genetic FSGS. And finally, beyond making a diagnosis, the nature of the variant that causes a disease can also give you clues to how to manage a disease. So Fabry disease is due to a loss of function in alpha galactosidase, which is on the X chromosome. You can have loss of function because there is a null variant in the gene, or you can have loss of function because the gene product is mistargeted and does not get to the lysosome where it has to do its thing. And the way you can treat Fabry is by enzyme replacement, which can be given for all, but you can also use a chaperone to take mistargeted proteins to the right compartment, and you'll need to know whether you have a missense variant that is mistargeted or a loss of function variant, so you can choose between agalsidase beta and migalastat. Finally, it can allow you to recognize extrarenal features or even anticipate future complications in a condition like Dennis-Trash syndrome or Fraser syndrome, which comes from dominant variants in the gene WT1. You get FSGS or another pathological entity called diffuse mesangial sclerosis, both of which cause proteinuria and kidney failure at a young age. They also have ambiguous genitalia, but there is a distinction between these two syndromes that come from the same gene in their propensity to develop certain tumors. So with DDS, there's a propensity to develop nephroblastoma or Wilms tumor, which is where WT comes from. And one needs the screening ultrasound until age 8 to pick up nephroblastomas. On the other hand, if you had Fraser syndrome, which occurs in XY females, there is a risk for gonadoblastoma. So once you make a diagnosis of Fraser, you would want to propose a prophylactic gonadectomy in the streak gonad when that diagnosis is confirmed versus screening for nephroblastoma or Wilms tumor in Dennis-Trash syndrome. And then, of course, genetic testing allows us to screen at-risk family members. For the purposes of this talk, it's living kidney donors that want to donate to some person related to them who has kidney disease themselves. And for other areas that you're very familiar with, like preconception planning, this is also useful. But there are challenges with genetic testing, and in nephrology, that's the lack of distinguishing phenotype that can make classification challenging. You can have an incomplete phenotype, you can have overlapping phenotypes and phenocopies, and I think you are quite familiar with this concept. For nephrologists who don't have the luxury of a genetic counselor or a geneticist, there's also the challenge of knowing what test to order and how to order it. And you have the choice between a limited panel or a targeted gene testing versus a larger panel or even exome or genome sequencing. For a condition like ADPKD, there's just a handful of genes. For a condition like FSGS, there's 40 plus genes. And we're becoming aware now that in addition to the traditional glomerular genes, non-glomerular, non-FSGS genes appear to cause FSGS, including genes like TTC21B, that's a cause of juvenile nephronophthisis. Also importantly, syndromic genes that cause Alport or nail patella syndrome are increasingly recognized as causing non-syndromic isolated kidney disease. So if you were waiting for deafness to think about Alports, or nail or patella changes to think about nail patella syndrome, you might miss several genetic causes of FSGS. There's the issue of the expensive test, again, something you're very familiar with. There's the issue of interpreting test results. There's obviously the risk of testing, one of the many roles that you play in conveying these risks to patients. And clearly you're needed, but if you didn't know this already, the field of nephrology desperately needs genetic counselors interested in nephrology. And I'm fortunate to have Maggie Fries as a dedicated renal genetic counselor. But most nephrologists, transplant centers, and even major academic centers don't actually have genetic counselors housed in internal medicine, let alone in nephrology. So if you ought to know then what the diagnostic yield for genetic disease is in end-stage kidney disease. And the best study comes from the study published in the New England Journal about 4 years ago. They looked at 3,300 patients. 2/3 of them came from the Columbia CKD cohort, but a third, importantly, were an ESRD cohort that were in the Aurora cohort. So these are unselected older patients who happen to be on dialysis, and they were recruiting them to test statins, clearly not enriched in genetic or familial kidney disease. What they found, at the bottom line, is they found that nearly 10% of patients had a monogenic disorder. So 307 of that cohort of 3,315, there were 66 distinct monogenic disorders, although just 6 genes accounted for 2/3 of the conditions, and that's PKD1, PKD2, and the 3 collagen 4 genes accounted for 5 of the 6, and the 6th was UMOD, a cause of autosomal dominant tubulointerstitial kidney disease. They looked at these 3,000 patients and classified them based on the clinical phenotype, and you can see that there's a significant number of patients with nephropathy of unknown origin, where 17% of patients had a monogenic disorder. So bottom line, in unselected populations of end-stage renal disease patients, as many as 10% of patients may have a monogenic disease, and many of them would be previously undiagnosed. What about kidney transplant candidates? So how are kidney transplant candidates different from the end-stage renal disease patient? Well, I can tell you that about 10% or less of the total end-stage renal disease population are eligible to get kidney transplants. That's just because of their comorbidities, their frailty, their psychosocial issues, or perhaps their advanced age that makes a kidney transplant no longer beneficial to them. And it is important to know whether these patients have a different diagnostic yield. They typically are younger, they typically are healthier, and so they're less likely to have diabetes, say, compared to the unselected cohort of end-stage renal disease patients. So there are 2 studies that I want to mention to you. The references are at the bottom of the slide. The first comes from Berlin, Germany. It's a single transplant center study of 635 patients. 18.7% had a known genetic cause of kidney disease, mostly ADPKD, but the half of the total number had an undetermined cause of kidney disease, and they took a select subset of those half that had end-stage renal disease prior to the age of 40 and found that 16% of them had an undetermined diagnosis, and they found diagnostic variants in that many patients. So overall, in that wait list, even though they were selectively testing only a fraction of the total number, 20% were shown to have a genetic cause of kidney disease. A similar study from another center in Germany had 20% with known genetic disease, mostly ADPKD, and an additional 4% with an undetermined diagnosis. So overall, in this study, 24% of the waitlist had a genetic cause. So bottom line, at least in Europe, the studies suggest that 20 to 25% of the patients on a waitlist may have a genetic kidney disease. Now for some case examples in nephrology and transplant. So this is a 26-year-old female with cirrhosis who's referred to us with chronic kidney disease, a serum creatinine 1.4. She's known to have congenital hepatic fibrosis with portal hypertension. We know that this kidney disease is chronic because she had a prior creatinine of 1.1, which is abnormal for a 21-year-old female. Her brother is reported to have one small kidney or an absent kidney. There's no other family history. That's the pedigree chart. The affected individual is shown with a blue circle, who's also the proband, shown with a pink arrow. This is what the ultrasound looked like. For those of you not familiar with ultrasounds, that's the right kidney, that's the left kidney. And what you see in here are these punctate white spots spread throughout the cortex and medulla of the kidney, which was read as bilateral punctate renal calcification, which is a feature of stone disease, if you will, or nephrocalcinosis. The CT scan with contrast showed normal kidneys. The MRI also showed normal kidneys, meaning these structures that were described as punctate renal calcification were not seen. Genetic testing identified 2 likely pathogenic variants in PKHD1. Both were missense variants. Both have been previously described in the disease ARPKD, that's autosomal recessive polycystic kidney disease. And this is something you're probably familiar with because you see it in pediatrics and in infants. Large kidneys without visible cysts in infancy because the cysts are small. Renal failure typically in infancy or childhood, and they have associated congenital hepatic fibrosis. So it turns out those bilateral punctate renal calcifications were not from calcifications, but from microcysts that were too small to be seen. But the back wall and the front wall of the cysts are so close together that the echoes from both walls sort of coincide and produce this ripple-like effect with the appearance of calcium. So the lesson here is that genetic renal disease can present with nondescript CKD, including the cystic kidney disease, ARPKD, and that childhood diseases do not have to appear in childhood, and late onset disease may look very different from early onset disease. Here's a second case. There's a 26-year-old presenting with new nephrotic syndrome. And again, for those of you who don't know what that is, it's a constellation of symptoms, which includes heavy proteinuria, low serum albumin, and peripheral edema. People with that symptom constellation are called nephrotics. She has an elevated creatinine, she has a low serum albumin, and she has a very high amount of protein in the urine. This is a kidney biopsy. This is a PAS stain. This is a glomerulus. And what this arrow points to is an area of increased pinkness, which is an increase in mesangial matrix, signifying an area of sclerosis. So it is segmental, involving a segment of the glomerulus, and the phenomenon only applies to some glomeruli. So it's focal and segmental glomerulosclerosis. You can see it is simply a descriptive term. And this is what the electron microscopy looks like. This is a glomerular capillary basement membrane. This is the endothelial side. This is the podocyte side. And usually you would see interdigitating foot processes. Here they're completely effaced. And complete effacement of the foot processes is thought to indicate that this condition is primary FSGS, meaning no known cause, all based on the electron microscopy appearance and the presentation of nephrotic syndrome. And the typical approach in nephrology is to give them a therapeutic trial with high doses of steroids for 12 weeks. That's a pedigree chart. There is no family history. She is a nurse. She came to the renal genetics clinic because she didn't want to take steroids and requested genetic testing. We proceeded to test her, even though she was classified as primary FSGS, and we identified a heterozygous variant in TRPC6, a missense variant which was classified by ACMG as likely pathogenic, and we called her autosomal dominant FSGS. We advised her not to take steroids. That's just the sequence chromatogram to show you the missense variant with a double peak at this position compared to the control gene. By the time we got all this testing done and treated her with lisinopril and furosemide, her nephrotic syndrome gradually improved. And 2 years later, she has a remission of her nephrotic syndrome, no protein in the urine, normalization of serum albumin, and an improvement in her serum creatinine. So lesson here is that genetic FSGS can present as primary FSGS, that primary, including genetic FSGS, can remit spontaneously. And for clinicians, this finding would allow you to avoid using steroids or immunosuppression that come with its own toxicity. Here's a third case, a patient presenting for evaluation of asymptomatic hyperkalemia, first identified 8 years earlier. He has no thyroid disease, no history of muscle aches or hypertension. That's so that you might think about muscle aches as a source of rhabdomyolysis or hyperkalemia. Thyroid disease because of the well-known association of hyperkalemic periodic paralysis with thyroid disease. He was being treated with a potassium exchange resin called KX-late or sodium polystyrene sulfate and a potent diuretic called furosemide without much success. The daughter also has hyperkalemia. You can see the proband and the daughter with hyperkalemia, but without hypertension. That's a laboratory data on the proband, high potassium, normal bicarbonate, normal creatinine, normal GFR. The transtubular potassium gradient is a way for us to determine if the kidney is responding appropriately to the hyperkalemia by increasing potassium excretion. And if it is, then it isn't a kidney problem. Or if the kidney is being inappropriate, suggesting that it is in fact a kidney problem. And this is a low TTKG, implying a defect in potassium secretion by the kidney. So there's chronic hyperkalemia without acidosis or hypertension, unresponsive to furosemide and KX-late. So the clinical diagnosis would be Gordon syndrome, which is an autosomal dominant condition, typically presenting with familial hyperkalemia. And the textbook would tell you that it is with hypertension. So it's also called FHH. He went on to have genetic testing done, and he has a heterozygous missense variant in KLH3, establishing a genetic diagnosis of autosomal dominant Gordon syndrome. And that's the chromatogram. You've already seen an example of it. The nice thing about making a diagnosis of Gordon syndrome is that there is specific therapy for it, very simple, inexpensive therapy, and that is to switch them from a loop diuretic to chlorthalidone, which is a diuretic of the distal convoluted tube, the site where Gordon syndrome defect originates. And it is a very effective and simple way to treat this condition. And you can see follow-up in 6 months, normalization of his potassium. So it's helpful to make a genetic diagnosis because you can target therapy based on the pathophysiology, which is directed by the genetic diagnosis. And in case you were wondering how KLHL3 impacts ion transport, KLHL3 is part of a ubiquitin ligase complex that is responsible for inactivating a kinase called Wink4 that in the absence of an activation activates a downstream kinase, which then activates the thiazide-sensitive sodium chloride cotransporter. Increased function of this leads to hypertension, reduced function of a potassium-secreting channel called ROMK, also by the same mechanism, leads to the hyperkalemia. All right, we'll switch to the second portion of the talk, which is living donors. So we move from people with disease to people who are completely asymptomatic and to all intents and purposes appear normal, meaning to be accepted as a living kidney donor, you have to pass a battery of tests, demonstrate perfectly normal kidney function, normal imaging studies, no hint of kidney disease. So you're moving now from symptomatic testing to asymptomatic testing, or depending on their risk, pre-symptomatic testing. Why is this important? Because we know that the act of donation, even in the healthiest donor, leads to a small but definite increased risk for end-stage kidney disease in the future. And that risk is increased if the donor is biologically related to their intended recipient. So a first-degree relationship indicates a higher likelihood of end-stage kidney disease over a period of 25 years compared to those without such a relationship. And this is ESRD per 10,000 population. So the risk takes many years to manifest, but it clearly separates out after about 15 or 20 years. And the adjusted hazard ratio for end-stage renal disease for a first-degree relative who's donating is about 1.7. And this is important because 40% of the roughly 8,000 living kidney donors in the US a year are biologically related to their recipients. The second study looked at the nature of the relationship from parent and child and sibling to even twin. And you can see the adjusted hazard ratio for parent, sibling, and child is about the same, 1.5 to 2, while for an identical twin, it's nearly 20-fold. So how do we proceed to evaluate an asymptomatic living kidney donor for genetic disease? This is what we propose should be the approach. We don't want to start with the asymptomatic living donor. We want to phenotype the recipient candidate in a case where a living donor has a related person with kidney failure. And that usually is the recipient candidate. We would do history, physical, urine studies, try and review the existing imaging studies, existing renal biopsy, and consider doing genetic testing. All of this to establish a diagnosis or a differential diagnosis in the recipient candidate who may come to you with undefined, unclarified end-stage renal disease. You then want to establish a formal diagnosis in the recipient candidate, a diagnosis that is good enough to allow you to screen the living donor for that particular genetic disease. You might do genetic testing with a single gene or broad-based testing, depending on your suspicion of disease. Or you can sometimes use a different screening test. So in a living donor related to someone with autosomal dominant polycystic kidney disease, an ultrasound is very good to exclude disease in those over the age of 40 who have a first-degree relative with ADPKD. But it has limited negative predictive value the younger you are. So less than 40, it's 98.2, less than 30, it's 90%, less than 20, it's even lower. And for a living donor, you want a negative predictive value of 100%. So in this particular case, in a young person, you would start by testing the recipient to determine the genetic basis for ADPKD and then do focused genetic testing in the donor for the familial variant. Here's a study we recently published in Transplant International looking at our own strategy in the transplant center for the sequential approach. And so we had 24 transplant candidates who had a living related donor who we thought were at risk for the same potentially genetic disease. And so they were subjected to broad-based genetic testing. 22 of the 24 had next generation sequencing. One of the 24 had a different technique called probe extension MALDI-TOF for a genetic disease that is not picked up by next generation sequencing. And the last one of the 24 had chromosomal microarray to make a diagnosis. And one of them had a confirmatory test, MLPA. And we were able to confirm a genetic diagnosis in one half of these 24. So 12 of them had genetic disease. You can see the vast majority were PKD1. The next big group is called for A3 and A5 and a scattering of others. This is just to give you the diagnostic rate, depending on the phenotype. It's very high for cystic kidney disease. And then we use this information on this 50% of recipients with confirmed genetic diagnosis to screen their related living donors. So 12 recipients that were positive here had 17 related donors. And you can see the vast majority of them were negative for the genetic variant, allowing donation to safely proceed. So 6 of 7 PKD1 related donors were negative, and all of them were under the age of 30, where an ultrasound was not sufficient to exclude disease with certainty. Clearly, some are positive and were counseled against donation. 4 of the 4 with COL4A3 and 1 of the PKD1s. So now some examples of how this might work. Here's a patient with clinically suspected hereditary nephritis, probably Alport's. And you can see this pedigree chart. There is 3 generations. This is the proband who needs a kidney biopsy. He's got hematuria and stage renal disease. He's got lenticonus, but a normal audiogram with no hearing defects. His kidney biopsy shows FSGS, and Alport's can cause FSGS in the kidney, but it also had this characteristic abnormality of the glomerular basement membrane that can be seen in patients with Alport syndrome. The immunofluorescent finding was confusing and unrelated to the final diagnosis. The diagnosis is consistent with Alport's. You can see from the pedigree chart, it's consistent with X-linked inheritance, but it could also be autosomal dominant. And why is all this important? Because this 36-year-old sibling wants to be a donor. She has no proteinuria, no hematuria, no hearing defects, and a slit lamp examination shows no lenticonus. Does that mean she does not carry the Alport gene variant? Well, not necessarily, because first, we don't even have proof that the recipient has Alport's. Second, we don't know the negative predictive value of a negative slit lamp exam and a negative urinalysis in a person with Alport syndrome with an undefined mode of inheritance. Genetic testing confirmed that there was a pathogenic variant in an intron that affected splicing in the X-linked gene COL4A5, confirming X-linked Alport's, and the donor was then screened and cleared to donate. Here's another example. This is cystic kidney disease with a negative family history. So here's the background. That's the proband. He's 28-year-old. He's got very large cystic kidneys with stage 5 chronic kidney disease. To all intents and purposes, this is autosomal dominant polycystic kidney disease. Both parents want to be donors. Both parents end up getting imaging studies. They don't have cysts. So they clearly don't have whatever their son has. But they both are unable to be donors themselves because of their other medical conditions. And so the 26-year-old sister wants to be a donor. She has a screening ultrasound. She has no cysts. You could assume that if the parents don't have disease, this arose de novo in the gamete, the sperm or the egg that led to this particular individual, but you can't be sure because we really don't know if there's a possibility of misattributed paternity. So you proceed with genetic testing of the recipient candidate. He's got a pathogenic variant in PKD1, so he has ADPKD from PKD1. And then it's simple enough to counsel the sibling donor and test her for that single base change in PKD1, and she proceeds to donate. Here's another example. This is titled Just IgA Nephropathy, ? 62-year-old female who presents to the transplant center with CKD5 from IgA nephropathy, a very common cause, usually an acquired disease, but it can have a genetic basis. You can see that that's the affected individual who has end-stage renal disease or CKD5 who needs a transplant, female, no family history of kidney disease. And her 40-year-old daughter, shown down here, wants to donate, and she passes all the tests, but she has microscopic hematuria, the only abnormality. And so clearly there's something here that is outside the normal realm of for a kidney donor. And it turned out that a sister to the proband had a history of deafness, but no kidney disease. This is just to tell you that the kidney biopsy, to all intents and purposes, looked like IgA nephropathy. On immunofluorescence, this glomerulus lights up for IgA in a segmental granular distribution. But because there's hematuria in the donor, we wondered whether the recipient might also have a genetic condition that could contribute to her kidney disease. And it turned out she has a heterozygous variant in the gene called 4A3. It's a likely pathogenic variant. It could be sufficient to cause the disease that she had, but she also had IgA nephropathy, and it was difficult to know which of these or both were contributing to CKD. We proceeded to test the daughter for this particular genetic variant, and sure enough, she carries the genetic variant too. So she likely has autosomal dominant Alport disease, although very, very mild because she had normal kidney function, no proteinuria, and just microscopic hematuria. And we advised her against donation. So here's what we would suggest as our approach to a living donor candidate. You have the living donor candidate. If the family history is positive for either known or suspected genetic kidney disease, or an unknown cause of kidney disease, especially early onset, or if there appear to be multi-system features, you would want to consider this living donor candidate as somebody who ought to be counseled about the option of genetic testing. You counsel both of them, and then you proceed to test the recipient first. If the disease in the recipient is known, you can do disease-focused testing. Otherwise, you do comprehensive testing. If the disease is unknown, you will need to do comprehensive testing since you don't really know which phenotype to focus on. And the outcomes for both sides are the same. You can test negative, you can confirm the diagnosis, or you can be left with uncertainty, where you either have a VUS or you get a pathogenic variant, but there is a phenotype mismatch. So you get a PKD1 pathogenic variant in a person who doesn't have renal cysts. That is a phenotype mismatch, and it would suggest that that PKD1 variant is not the cause of disease in the recipient. Testing is negative, you would counsel the living donor about the residual uncertainty because you now no longer have a tool to test the living donor. If the diagnosis is confirmed, you proceed to test the living donor for the familial variant, and if positive, you counsel against donation. If negative, you would permit donation. Occasionally, living donors with or without a family history can have some minor abnormalities such as hematuria and a few cysts that you could consider genetic testing for, but it would be phenotype driven, not asymptomatic donor driven. And whenever we do testing on transplant candidates or any patient with a possible genetic disease, obviously you want to counsel them first, choose the appropriate gene panel, and then you know what happens. You sometimes get a VUS, sometimes you get a likely pathogenic. You need to first make sure it matches the phenotype. Then you need to confirm that conforms to the disease mechanism. That is, the zygosity matches the inheritance pattern, that the variant matches the molecular mechanism. And then you would proceed to determine if this is appropriate and relevant for the person, or whether this is just a VUS at the end, where you might need to do additional studies. When the testing is negative, you need to decide if additional tests are required that might not be picked up by standard next generation sequencing, such as the probe extension that I talked about for a gene called mucin-1. And I'm going to conclude here by telling you that incorporating genetic testing into nephrology practice informs diagnosis with a wide variety of renal phenotypes. And at least in Europe, genetic disease accounts for 20 to 25% of the waitlisted transplant population, from where around 40% will have a living related donor who might be at risk. The genetic disease in the US waitlisted population is likely to be lower, but perhaps not by much. We know for sure that 8 to 10% of patients on the wait list in the US have autosomal dominant polycystic kidney disease. Genetic diagnosis, I hope you'll be convinced that in transplant candidates helps with pre-transplant planning and with perioperative and long-term post-transplant management, as with primary hyperoxaluria, where the treatment isn't an isolated kidney transplant, but a combined liver and kidney transplant, or atypical HUS from CFH, where you would use eculizumab perioperatively. And finally, sequential genetic testing of living related donors for inherited renal disease promotes informed choice and enhances the safety of living donation. And I want to end by thanking Maggie, my compatriot and collaborator, who I'm fortunate to have in the Renal Genetics Clinic as a genetic counselor, and for the others in the Iowa Institute of Human Genetics that has helped us to deliver a homegrown genetic panel for testing our patients. With that, I'm going to be available for questions, and I'll hand the platform back to Amber.
Thank you so much, Dr. Thomas. That was an excellent presentation. So at this time, we're going to begin our Q&A. Please remember to submit any questions using that Q&A box. We already have a couple coming through. So the first question is, are there screening recommendations for asymptomatic relatives who test positive?
So I would struggle with that question only because screening applies to the asymptomatic relative before they have tested. If you mean what are the follow-up recommendations for an asymptomatic living donor who tests positive, I'm happy to answer that. So in a person with polycystic kidney disease who tests positive, whose asymptomatic young sibling also has a positive genetic diagnosis but does not yet have manifestations of disease, I would refer them to a nephrologist. What does a person need before they develop genetic visible disease? They would need close monitoring of their kidney function. They would need to have their blood pressure monitored, and they would need to be aware, that's the asymptomatic, pre-symptomatic living donor now who has tested positive, need to be aware that we finally have an FDA-approved treatment for autosomal dominant polycystic kidney disease. And so as soon as a person qualifies for that therapy, you would want them to be ready, because the earlier you start the treatment, the longer you can prolong their kidney function and delay the onset of dialysis. But you would only start treatment once disease appears. And so making a pre-symptomatic genetic diagnosis of a type such as ADPKD is pretty profound and can be difficult for the donor, which is why it's very important to counsel an asymptomatic person whose only motivation to come to a transplant center was to give up one of their kidneys. They're not necessarily prepared to learn that they have a genetic disease themselves and have to anticipate that. It may also be helpful for an asymptomatic young woman who tests positive, is of reproductive age. She may want to consider preconception planning for her own future children. But that's what you would want to do with positive testing, and just to send them to an appropriate provider who can counsel them, help monitor for disease, and give them general advice on maintaining their health.
Great, thank you. Our next question is kind of two parts. So it says, will the living donor transplant recommendation become a practice guideline? And then how do we as genetic counselors spread the word about genetic testing in nephrology?
Oh, so that's actually there's looks like three parts to the question. So let me try and discuss the first one, which is, will this become a guideline? So I think you heard in the introduction that I am part of two work groups, one from the American College of Medical Genetics, and we are working on a systematic evidence-based review followed by evidence-based guidelines, which we're early in the process. And I know from my own published work and from my own review of the literature that there are very few, if any, published resources to help guide the community. So our systematic evidence-based review may come up short, but we will use the available information to come up with an evidence-based guideline. That's the American College of Medical Genetics. I also chair a work group from the American Society of Transplantation to address this very question. What we have just submitted for manuscript review is essentially a practice resource. We make no bones about the fact that there's very little evidence. And the evidence you'd want to know is, does this kind of testing of asymptomatic people actually promote benefit, or does it only contribute to more risk and uncertainty? And this is important because transplant centers do not have the expertise to know what test to order, how to go about testing an asymptomatic person. Many don't get counseled before testing. Many don't get counseled after testing, even if they're positive. They're simply excluded as a living donor and dismissed from the transplant center with no further follow-up. So our practice resource is meant to allow transplant professionals, both nephrologists and transplant surgeons, to responsibly approach living donors who might be at risk, and to be sure to counsel them and provide them the resources they need. Which is sort of a segue into your second question, is how can genetic counselors be more involved? I think nephrology is likely to be the next big frontier for genetics. And it is in its infancy. It requires nephrologists to start to develop an interest in genetics, set up renal genetics clinic, and it requires genetic counselors to have an interest in nephrology, and hopefully the two groups that are in the same place at the same time can come together and help expand the scope of a renal genetics clinic. But I would urge you who might have an interest in kidney disease to figure out how you can make yourself available to your nephrology group in your local academic medical center or in the community, and help them with the knowledge and expertise you have. And in the process, you will learn from them about distinct renal phenotypes and when to use focus testing, when to use comprehensive renal gene panel testing, and so on. So I think this is a great area for genetic counselors to get involved in. It's the next hot area of genetics in adult medicine after cancer genetics, I think.
Great, thank you. Another question that we have is, how do you choose a living donor for an individual with a personal and family history suggestive of ADPKD, but negative test results?
Yeah, it's a great question. So, one of the things that we do in living donation, which I think you ought to be aware of and be familiar with, is the idea that we are letting normal, healthy people put themselves in harm's way, not for their own benefit, but for the sake of another. We as a society and we as a practicing transplant community believe that it is appropriate under the right circumstances to give that living donor the autonomy to make such choices. So what do we do with a person who is related to a person with a likely or definitive genetic disease, but we don't have a genetic test to confirm it in the recipient? The best we can do is counsel the living donor about the residual uncertainty. We haven't confirmed genetic disease in the kidney disease candidate. With polycystic disease, about 7% of the time we cannot find a genetic basis. And depending on the age of the living donor, the residual uncertainty may be small. So if the living donor is 35 years old with a sibling with ADPKD, a negative ultrasound has a negative predictive value of 98.2%. And 7% of the remaining 1.8% may test genetically negative. So the residual uncertainty may be small. You as a professional and the patient as a patient have to take a shared approach to make a decision about the residual uncertainty, whether it's too much to take or not, and individualize the decision about donation. So we try and if you will, move away from provider paternalism in this instance and allow the donor to make a decision, providing the donor is well-informed, educated, and can understand residual risks.
Sorry, muted myself. Another question here. Can you comment on the utility of APOL1 testing for donors?
Yes, I can. So I did not bring that up in my presentation because my topic was already very broad, and APOL1 testing is a hour-long talk on its own. So APOL1 is a gene that it turns out is a very strong risk factor for chronic kidney disease and end-stage kidney disease. The effect size of those risk alleles in the gene APOL1 is so large, it is almost Mendelian, but not quite, because inheritance of 2 risk alleles in APOL1 sets you up for future kidney disease, but it isn't sufficient to cause kidney disease. So what is APOL1? So it's a gene that arose late in evolution. It isn't there in earlier species, and there are no suitable natural animal models. It turns out that APOL1 gene variants that can promote or provoke kidney disease arose in sub-Saharan Africa because the single copy of APOL1 risk variant, so there are 2 risk variants that cause kidney disease. A single copy of either of those risk variants protect against the African form of sleeping sickness. And so in sub-Saharan Africa, there's very high heterozygous carriage rate for the APOL1 risk alleles. And to this day, APOL1 risk alleles are only seen in people that have recent sub-Saharan African ancestry. In the United States is those that came here with the slave trade. So African Americans, Afro-Caribbeans, Afro-Brazilians, wherever there was the slave trade, there is a high carriage rate. So 2 risk alleles are present in 13% of self-identified African Americans and 1 risk allele in 39%. If you have HIV, your risk of HIV-related kidney disease secondary to APOL1 risk alleles goes up about 80 to 90-fold. That's 80 or 90-fold. If you have hypertension, your risk of kidney disease from hypertension goes up several-fold, 10 to 20-fold, and so on and so forth. But because it is only a risk allele, and because there's a high carriage rate in the normal population, we need to be very careful about how we use this testing to handle living donors who want to give up a kidney. We don't know if a nephrectomy on top of APOL1 risk alleles becomes a second hit for future kidney failure. And in the African American community, as in other minoritized populations, there's already disparities in access to transplantation, in the ability of a living donor to be approved for donation. And by having indiscriminate use of APOL1 testing to exclude living donors, we may widen that disparity. So in our own practice, and we've written a guideline on behalf of the American Society of Transplantation. In our own practice, we offer every living donor of the appropriate ancestry information about APOL1 testing, give them the option of getting tested, and we truly allow them to make that choice. If they turn out positive, we counsel them again and give them the option of proceeding, providing they have no other risk factors. That is, they have no evidence of prediabetes or some other independent risk factor that might promote kidney disease. And if they're again well-educated, well-informed, and especially if they're of an older age, we will allow them to exercise their right to make their own informed choices. But most centers may automatically exclude with testing.
Great. Well, we're basically at the top of the hour, so I think we'll stop questions there. So to all of our attendees, thank you for attending today's webinar. And a huge thank you to Dr. Thomas for sharing your expertise and experience. This webinar recording will be posted to the webinar page of NSGC website within 48 hours. We look forward to seeing all of you at our next webinar.
And thank you all for giving me this opportunity. This was a privilege.